Thank you, Dr. Stefanacki, for inviting me here. It is my great pleasure to be standing in front of you. Great honor to be part of this excellent scientific program that I saw in the last days. Congratulations for those who survived till one of the latest sessions, but please make sure that you stay also for the angioedema roundtable, because it is going to follow just after my presentation. So the topic here is the definition, acronyms, nomenclature, and classification of angioedema. And I would just briefly disclose that this presentation contains some speculative and unproven hypotheses on links between Sumerian and Greek mythology. So it is my great pleasure to be in this city for the very first time in my life. This is the city of Ioannina, the hometown of Thalia. Thank you for inviting me, but I was curious to understand a little bit more about your town. We know that Ioannina or Iannina is the name coming from Agioannina, or the place where Saint John is said to be linked with the establishment of the monastery dedicated to the Saint John the Baptist. And after this settlement, the city grew up. So most of you probably yesterday attended the city tour, also seeing remains of this castle. And what is interesting here is that Saint John is one of the patrons of love, loyalty, and friendships. So an exciting place to be standing in this symposium. But I'm making here just a link with the Sumerians, with a glimpse whether Ioannina has something, or Iannina has something to do with Inanna. And Inanna, most probably some of you have heard her name, much more popular, is the name Ishtar. Ishtar is the goddess in ancient Mesopotamian mythology, and she was responsible of love, war, and fertility. She is also associated with the sensuality, procreation, divine law, and political power. Her primary title was the Queen of the Heaven, and she possibly influenced some images of Greek mythology, including the goddesses Aphrodite, Artemis, and Athena. So this is the genealogy of Sumerian Akkadian gods, and here is Ishtar, or Inanna, who is a granddaughter of the highest god Anu, who was the god of the heaven, and then his wife Namu, who was like the mother goddess, and she gave birth to the greater gods. And Ishtar, so this is my introduction, to lead you to this entrance to the Ishtar Gate. And Ishtar Gate is one of the symbols where we have maybe the biggest theft in archaeology documented. It was the archaeologist Robert Caldwell who relocated this entire monument from the city of Babylon in Mesopotamia through boats, and is now currently reconstructed into the Pergamon Museum in Berlin. I highly advise you to visit. Most probably, if it was still in Babylon, we would not be able to visit now, but in Berlin, we could definitely see this mythical gate. Why this gate is interesting? Because it led to the entry of the procession way in the sacred part of the Babylon city, and the Babylon city was known and very special for containing this secret, which was the Babylon Tower, which was kept in the very heart of the city. And the Babylon Tower is a symbol of the human power once we speak the same language, the power that we have to aim for the sky and to reach the heaven where the gods live. But as you know, this was a disrupted plan because people stopped speaking the same language because of the gods who decided to create different languages. So maybe this was the only problem I had here, not speaking Greek language to enjoy the entire conference program, because there were a lot of interesting topics. So hopefully I would augment in next visits with some Greek lessons. But this is also what happened with angioedema. We're speaking about angioneurotic edema, like Queen Kate called it. Then we have the hereditary Hane. This was pretty popular in Bulgaria. I don't know if in Greece was popular as well. Then histaminergic angioedema, idiopathic angioedema, recurrent swelling, and quick disease. It might be the same disease, or maybe it's not. So we really do not know because we don't speak the same language. So thus, the dance project was born, and this is the topic that I'm going to speak here about. So the dance project was aiming for defining new definition, establishing acronyms, nomenclature of angioedema, classification of all edema conditions. And it was a project run by the ACARE network. So these are the network of centers of reference and excellence that is supported by Galen and HEI. And this project contained the opinion of 91 experts from 35 countries. And this project was endorsed by 53 science societies and organizations. It was published just last month in August in JACI, and it was led by Professor Avner Lischev and Thomas Budgereit from Germany. So this is what we have different in the definition of angioedema. We know that it is paroxysmal, it's localized, and what is new here is that it's self-limiting. So this swelling can affect the subcutaneous or submucosal tissue, and it varies by intensity and frequency over time, and outside the episodes, patients are symptom-free. But what we know also is that angioedema, it was the little prince who said it, that it is, what is important is invisible to the eye. It might turn out that all these patients look the same to you, but they have every one of them has a different disease, and this is the problem, one of the major problems in angioedemology. So if we want to know better for our patients and serve better their needs, we need to look further. And it was the pivotal consensus by Professor Marco Ciccardi that was published just 10 years ago, and this provided the first extensive evidence-based foundation that included all known at that time forms of angioedema, including incidence, clinical presentation, pathogenesis, diagnosis, and treatment. And you see here that it was the first to formulate this angioedema-specific vocabulary that enhanced medical reading much better. So this was one of the goals of the current project, to facilitate comparison of results of studies, also collaborating between centers, and also to harmonize angioedema care worldwide. So these are the principles that are followed. So we have AE for angioedema, HAE for hereditary form, C1 inhibitor is removed with a removed dash. The AAE is only kept in the cases of acquired angioedema due to C1 inhibitor deficiency. And we have some new terms, the MC, which is the mast cell, the BK, the bradykinin, and the ACE inhibitor here. So very simple in order to serve better the clinical practice. And this is it. So this is the baby that was born by the DANCE project, the new classification, defining 3 endotypes in which we know the pathogenetical and pathophysiological mechanisms. So the mast cell mediated, the bradykinin induced, and the one with intrinsic dysfunction of the vascular endothelium. You're going to hear much more about it by Professor Germanis in the next talk. And then we have 2 types, which we know they are heterogeneous, the drug-induced and the unknown that was historically kept here. So mast cell, or I would make a joke here, it's the most common as well. So when we hear clatter, we're not thinking about zebras, we're thinking about horses usually. And it might prove that it is useful for the clinical practice to show the patient the wheal, to just ask the patient, did you have wheals once in your lifetime before, or do you have it sometimes concurrent with angioedema presentations? And it might turn out that the patient says that this is edema and this is, for you as physicians, is urticaria. But also we know from the definition of chronic urticaria that this condition might be urticaria, angioedema, or both. And there is an isolated form of chronic urticaria that doesn't present with wheals, it only presents with angioedema, and it is up to 6% of these patients. Of course, some of you would argue that these forms are not chronic urticaria, they're idiopathic or recurrent angioedema. There have been some dispute in the expert level, and I would agree with you because we know that there are many pro and con to call this condition chronic urticaria without having any urticaria, because we know that there are some differences in the clinical presentation, like the patients with angioedema only having more tongue swellings, for example, and also there is difference between female to male. So we know the chronic urticaria is much more frequently presented in females, while with angioedema only, it is more frequent in males. Also, there is difference into the response of different therapies. Antihistamines seem not to work very well in these patients, while omalizumab is maybe the most, the best answer to therapy is actually in this field. So this is chronic urticaria angioedema only, this is wheals and angioedema, and this is only wheals. And you see that the perfect 100% complete response is only seen here in this group. So it might turn out that therapeutic answer might be part of the diagnostic workup when dealing with such patients. And the next endotype, the one that is bradykinin mediated, I'm making a joke that you better know it. So it's a very rare disease, maybe not on a daily basis part of your clinical practice, but it is very dangerous because it might come that these patients need upper airway management in cases of emergency. It also affects some other places that are not presented in the mast cells, like abdominal crisis, much more frequent genital attacks, and also severe swellings of the extremities. We know that here the pathophysiological mechanism is the contact system disequilibrium. When we have the factor 12 active, cleaving prekallikrein, then cleaving kininogen, releasing bradykinin, and thus in that kind of angioedema, we do not have any therapeutic improvement upon conventional anti-allergic therapy. And we have various genetic causes. So the genotypes here is the most frequent SERPING1 mutations, but also the less frequent normal C1 inhibitor HE, factor 12 plasminogen, kininogen 1, and there are some disputes about the carboxypeptidase N. So do we need genetic testings? Usually no, because we usually have the diagnostic workup with just complement testing, C4, C1 inhibitor concentration and function, and it turned out that we easily diagnose types 1 and 2 C1 inhibitor HE, and the acquired form of C1 inhibitor deficiency, you know very well, this is the cases when we have excessive consumption of the protein or neutralizing antibodies who make it non-functional. In these cases, it might turn out that if you have late onset, no family history, better test for C1q as well. It might turn out that it's low in the acquired form. But genetic testing usually not needed, except for some rare cases when we have inconclusive measurements of C4 or antigenic and functional levels of C1 inhibitor. You know, in newborns, we might not assess the complement system because it's still not mature, and in asymptomatic relatives. So this is the statement 1 of the international consensus of the genetics in management of angioedema run by Professor Germanis. So in these cases, it might turn out that it's good to have genetic testing here. And also it is important to diagnose the other forms of non-C1 inhibitor HAE. And here we come to the next endotype, which is the angioedema due to intrinsic vascular endothelial dysfunction, or the very extravagant brand new concept. So we know here that there is a disequilibrium in the level of the endothelial cells. We have here various genotypes: angiopoietin 1 mutation, myofurlin, heparan sulfate, and the recently described DAP2IP. Some of them are accounting for VEGF and VEGR missignaling, and some of them are also accounting for different changes in the glycocalyx when we have susceptibility of having endothelial dysfunction. These cases remain a therapeutic challenge because in such cases we don't have actually a lot of evidence how the currently available therapies might be a matter of therapeutic answer. Here also we had the expert panel voting for the systemic capillary leak syndrome, a very, very rare condition. As far as I'm aware, in my country has never been described. This is the so-called Clarkson disease. Now, I would argue it's not angioedema, it's a systemic disease, and it comes also from time to time. So this condition was also classified under this category of vascular endothelial angioedema. And the next type, here we do not have endotype, but just type, is the drug-induced angioedema, or I would make the joke, it's a drug intentions of some therapies. We might have drug-induced angioedema in those cases that we stop the therapy and there is no angioedema more. And there are some cases when we have drug-exacerbated forms, like the NSAIDs being the exacerbators in mast cell angioedema in up to 30%, and also the ACE inhibitors being non-exacerbators of C1 inhibitor deficiency. So the main three, I would say, therapies that are known to induce angioedema are the modifiers of the renin-angiotensin aldosterone system, the ACE inhibitors, tissue plasminogen activators, and DPP4. But I think also with neprilysin there are some reports now. And also the next is the modifier of the arachidonic acid metabolism, usually in mast cell angioedema, when we have NSAIDs as inducers of angioedema. And we have the hormones, estrogens, and also estrogen receptor modifiers like tamoxifen that might turn out to cause angioedema as well, or exacerbate angioedema in some cases. I think a good question for clinical allergy practice is, can we use sartans in the case of ACE inhibitor angioedema? And the answer comes from the Danish cohort that was published in 2019. And you see that it is run over 1,100,000 people. And it turned that 5,500 had ACE inhibitors. So this calculates the incidence of this condition to be 0.5% in the exposed to ACE inhibitors cases. And they answered the question. You can see here the hazard ratio for ACE inhibitors. Surely you should not reintroduce such therapies in patients with ACE inhibitor angioedema, but for the sartans, this is very low. So the advice of this group from the Danish cohort say that sartans can safely replace ACE inhibitors, and it might turn that it's important for your patient to receive such a therapy in order to the benefits according to the cardiovascular system protection that these therapies give. And last but not least, the angioedema unknown type. So the expert panel decided to keep this term unknown just to push us forward that we need to know better for these patients. So we know that it is a heterogeneous disease. We might try to translate whether there is family history, whether it's HE or just angioedema with no hereditary trait. And here they also classified the so-called Gleich syndrome. Gleich syndrome is the ultra-rare episodic angioedema with eosinophilia. And Dr. Gleich was a consultant of the group during the process of the Delphi process of establishing this project. And Dr. Gleich, who described the disease, he said that we certainly nowadays do not have enough data, whether it's the eosinophils that drive to angioedema, or it is mast cell activated, or it is interplay between both. So we decided to keep this condition under the unknown angioedema form. And here I would like to highlight that genetic testing in this type of angioedema should be performed whenever possible, because we know that at least 35 patients, according to this literature, were found to have either factor 12 HE or plasminogen HE, and they were initially misdiagnosed as unknown. So here is the recommendation number 3 of the European YACI-WOW guideline for the management of HE that states that we recommend that all patients who suspected to have HE and normal C1 inhibitors should be evaluated for the known mutations that are known to underlie HE with normal C1 inhibitor. So HE with normal C1 inhibitor, now we recognize at least these 8 genotypes and still counting. So we know that 3 of them are believed to be related to the bradykinin angioedema endotype, the factor 12, the plasminogen and kininogen mutation. We have 4 of them attributed to possibly be related with vascular endothelial dysfunction, the angiopoietin-1 mutation, the myofurlin, heparan sulfate, and the DAP2AP. And currently, the last described, the carboxypeptidase N, is not really easy to classify, because we know carboxypeptidase N is a degrading, so it is an enzyme, a peptidase that degrades bradykinin, and still we do not know what is the exact interplay between bradykinin degradation and mast cell activation, because these patients are described to have urticaria. I know that there are some discussions, maybe Professor Girmenis can tell more, but here I would not go into details because it is a difficult situation to describe and interpret. But just short, brief clinical glimpse to the various genotypes of normal C1 inhibitor HAE. So these are all the mutations that were described with the respective chromosomes that are affected and the number of patients and families. And what is interesting is that we have most of cases actually discovered in factor 12 or plasminogen, and in the other mutations we just have single families affected. The male to female ratio is different. The family history, we know there is incomplete penetrance of these conditions very often. So it is not very easy to assess family history. The onset of age is quite different, and the exacerbating factors are different. Estrogens are known to be exacerbators in some cases, while others report mainly physical stimuli. And I think from a clinical point of view, the angioedema site described is the thing that might be helpful for your clinical practice. We have most of them affecting the orofacial zone, but for example, the plasminogen mutation affects very frequently the tongue. And abdominal creases have been described with angiopoietin mutation, with kininogen 1, and also with heparan sulfate, only one family with 4 members, but these are distinctive features to my point of view, which might be of clinical interest. And why we are speaking about this neglected disease? Because we know HAE with C1 inhibitor deficiency is the spoil of the poor, while with normal C1 inhibitor, it is the poorest of them all, because we don't know, we don't have, there is a huge gap of available therapies, and the new classification may be not excellent, maybe not perfect, but it is aiming to potentiate research in those neglected angioedema syndromes when we don't have and try to facilitate bringing treatment options for those patients. And the expert panel in the DANCE project says at the end that the expert panel recommends that patients diagnosed with angioedema unknown should be followed up regularly, reevaluated, because this is a changing field, a lot of new things become available and known. And also given the best of care possible, including, if needed, off-label therapies. Because the aim here would be also to normalize patients' lives, what we aim also in the C1 inhibitor HE patients. And with this, I would like to give you the blessing of St. John, thinking about love, loyalty, and friendships that was started here in Ioannina. And I would also like to dedicate this talk in the loving memory of those who are not still already with us and who paved the current milestone of advancements in angioedema research. We lost a lot of great people in angioedemology in the last years, including Professor Marco Ciccardi from Milan, Dr. Ritu Moldovan from Romania, Professor Boșco Boșcov, who discovered this disease in my country, and just the recent untimely passing of Professor Maurer. And with this, I would like to thank you for your attention.